Welcome to Antibiotic Answers. My name is Haley Warner, and today we're talking about Candida auris. Candida auris is a fungus that spreads easily among patients in healthcare facilities, particularly those who are already sick or have multiple medical conditions. C. auris is known to cause invasive infections, such as in the bloodstream or a wound. Symptoms may not be noticeable in someone who is already sick and vary depending on where the infection is located. Since 2016, the number of clinical cases reported nationally has been on the rise. Between 2016 and 2024, there were 17,091 cases. 6,304 of these cases were reported in 2024 alone. There are multiple factors that contribute to how easily C. auris is spread. For example, colonization. This is when C. auris lives on a person's skin or other area of the body, but does not cause symptoms of infection in that person. Additionally, C. auris can survive on surfaces and objects for many months. So C. auris can not only be spread from an infected person, it can also be spread by a person with colonization or from surfaces and objects that are contaminated with C. auris. You can screen for colonization with a skin swab, usually from the armpit or the groin. People who have a positive screen for C. auris colonization are counted as a screening case. They have no symptoms and therefore do not require treatment. When C. auris is identified in a sample taken from the site of a suspected infection, this person is considered a clinical case. They have symptoms of infection and require treatment. Notably, C. auris tends to be resistant to multiple drugs. Drugs from the echinocandin antifungal class are recommended as first-line treatment. This table shows the recommended first-line treatment options for adults and pediatrics. Anidilafungin and caspofungin have loading doses followed by a fixed daily dose for the adults. Notice that anidilafungin is not approved for pediatric use. Caspofungin has dosing based on body surface area for pediatrics. Micafungin is a fixed daily dose for adults, but includes weight-based dosing for pediatrics. All three of these options are IV. Treatment for children who are less than 2 months old differs from that of adults and other pediatrics. In this case, the first-line treatment is amphotericin B deoxycholate. If nervous system involvement has been ruled out, caspofungin and micafungin can also be considered with caution. The recommended duration of therapy for suspected invasive C. auris infection is 2 weeks, assuming that patients show signs of improvement. This duration is based primarily on data from adult and pediatric studies. No data exists to guide duration specifically in neonates. For adult and pediatric patients, you may consider treatment with liposomal amphotericin B, given as 5 mg per kilogram per day IV when the infection is resistant to echinocandins or a patient treated with an echinocandin does not improve after 5 days. Infection prevention and control measures are particularly important in the case of a C. auris outbreak in a healthcare facility. Workers and visitors should frequently clean their hands. An alcohol-based hand sanitizer is preferred, but soap and water is a good alternative. Patients colonized or infected with C. auris should be separated from others who are at risk of infection. Clean and disinfect patient care areas as well as reusable equipment daily. And if you are providing care to a patient who is colonized or infected with C. auris, wear gloves and a gown. Thank you for listening to this Antibiotic Answers video. Please reach out to the CAP Center Antimicrobial Stewardship Pharmacist, Emily Perry, with any questions you may have.